Welcome to the Deep Dive, the show where we take a stack of information and really pull out the important stuff so you're instantly up to speed.
That's the goal.
Today we're diving into something quite complex, often pretty elusive in horse health. Equine abdominal abscesses.
Yeah, they can be tricky.
We've got a good set of veterinary sources here, detailed excerpts giving us a really comprehensive look. We'll explore what these hidden threats are, why they pop up, the detective work needed to find them, and the often very long battle to treat them.
It really can be a battle.
So our mission today is to give you a clear, thorough understanding of these internal infections. Essential knowledge if you own or work with horses.
Absolutely. So equine abdominal abscesses,
Yeah.
essentially they are localized collections of pus deep inside the horse's abdominal cavity.
Okay, pockets of pus.
Right. And what makes them so challenging and frankly quite sneaky is how hard they are to diagnose.
Why is that?
Well, the clinical signs are often really nonspecific. They don't scream abscess.
Yeah.
And their location, it can be incredibly deep, sometimes just inaccessible for easy examination.
So they're almost hiding in plain sight, or rather deep inside. And the danger, it sounds pretty dire if they're missed.
It absolutely can be. If one of these ruptures, well, that's a life-threatening emergency. The immediate danger is something called diffuse peritonitis, basically a severe, widespread infection flooding the abdominal lining.
That sounds awful.
It is. And they can also compromise vital organs, leading to major systemic problems and a very rapid decline in the horse's health.
A really serious threat then.
Yeah.
How do these hidden pockets of infection even, start? What's the process behind them?
Generally, we categorize them as either primary, meaning they originate from an infection somewhere else in the body that spreads.
Systemic spread.
Exactly,
Oh, yeah.
systemic spread. Or they can be secondary, maybe resulting from abdominal trauma, an ulcer, perforation, or even sometimes a complication after surgery. Now, what's particularly interesting with mesenteric abscesses, those in the membranes around the intestines, is that we don't fully understand the exact process.
Really?
Yeah. But the leading theory suggests it often involves the horse's immune system not quite managing to mount an effective localized response. This allows a systemic infection to sort of take hold and get walled off in the abdomen.
It's fascinating how the body tries to wall things off, isn't it? Like building a containment field.
It is. But if the immune system isn't quite winning that battle, does that mean these horses might have some underlying immune issue, or is it just the infection itself being very aggressive?
Good question.
It's often the latter, the sheer aggression or persistence of the bacteria. And these abscesses, they can be quite tricky. They might lie dormant for a while.
Sit there quietly.
Right. Or they can suddenly flare up, which leads to those varied clinical signs we mentioned. If a horse shows colic signs from an abscess, it could be due to tension on the mesentery, the membrane itself, or even an intestinal blockage caused by adhesions forming around the abscess.
Ah, adhesions. Scar tissue, basically.
Essentially, yes, internal scar tissue sticking things together.
That really explains why the symptoms can be so unpredictable. So it begs the question, how do these deep infections even get started? What are the common culprits?
Well, at their heart, it's usually a bacterial infection. One of the most common routes, especially in horses, is through what we call hematogenous spread.
Bloodborne.
Exactly, bloodborne spread.
And I've definitely heard of bastard strangles in relation to this. Sounds pretty ominous.
It does sound grim, and it certainly can be. Bastard strangles is a very common cause, particularly in younger horses. Think weanlings, yearlings.
Okay.
The culprit is Streptococcus equi subspecies equi. That's the bacteria that causes regular strangles, the respiratory infection.
Right, the one with the swollen glands.
That's the one. But sometimes it doesn't stay contained. It can spread from those lymph nodes in the head and neck to distant sites, and a common target is the mesenteric lymph nodes, the ones around the intestines. And that leads to abscesses forming there.
So a complication of a common illness spreading internally. What about other ways systemic infections cause this?
Well, really, any systemic bacterial infection, bacteremia, can potentially lead to abscesses forming in organs like the liver, kidney, spleen, or in other lymph nodes.
Okay.
This is particularly common in foals if they have septicemia, blood poisoning, which might start from, say, an infected umbilical cord, pneumonia, or severe diarrhea, enteritis.
Foals seem especially vulnerable.
They are. And speaking of foals, Rhodococcus equipneumonia, another common foal illness, can also cause what we call extrapulmonary abscesses abscesses outside the lungs, including abdominal ones.
Right.
And in adult horses, Corynebacterium pseudotuberculosis is another known cause of internal abscesses. You also see things like SCP subspecies, Zooepidemicus, Salmonella, E. coli, sometimes rarer things too.
It's quite a list.
It is. The key takeaway isn't necessarily memorizing all the names, but understanding the variety of bacteria that can cause these hidden infections. It really makes diagnosis and treatment a complex puzzle.
It absolutely clarifies the challenge. Now, I remember seeing a note about penicillin treatment potentially being a risk factor. That seems counterintuitive.
It's quite a nuanced point. The suggestion is that treating strangles with penicillin before an abscess, like in a lymph node, has fully matured and is ready to drain naturally. Well, that might actually favor the bacteria spreading hematogenously through the blood.
So interfering with the natural process could inadvertently help it spread.
That's the concern, yes. It highlights the complex interplay between antibiotics, the horse's immune response, and how the body tries to contain things.
Fascinating. Okay, so beyond bloodborne infections, where else might these abscesses originate?
The GI tract itself is another major source.
Their gut.
Exactly. This can happen through leakage or even a perforation, maybe from severe intestinal ulcers like gastric ulcers or dorsal colitis.
Right, dorsal colitis, that's inflammation of the large colon, right?
Correct. Or sometimes a horse might swallow a sharp foreign object that punctures the gut wall. It's also a known, though hopefully rare, complication of intestinal surgery. Even a tiny leak at an anastomosis site.
An anastomosis site. Remind us what that is.
That's where the surgeon has reconnected two pieces of intestine after removing a damaged section.
Got it.
And even a microscopic leak there can let bacteria out into the abdomen.
Creates an opening.
Precisely. And it's not just physical holes. Severe enteritis inflammation and damage to the gut lining caused by bugs like Salmonella or Clostridium that can compromise the intestinal barrier, make it leaky.
Allowing bacteria to cross over.
Yes. And even long-standing chronic inflammation, like chronic enteritis or colitis, can lead to abscesses forming right in the intestinal wall or the nearby lymph nodes.
What about external causes?
Yeah.
Can something from the outside lead to an internal abscess?
Absolutely. Penetrating abdominal wounds are a direct route in. Any trauma that breaks through the abdominal wall can introduce bacteria straight into the cavity.
Makes sense.
Less commonly, the infection might stem from the urogenital tract. Maybe an infected uterus, metritis, or an infected bladder.
Okay. Are there any general risk factors? Things that might make a horse more likely to develop one?
Yes, there are some factors believed to predispose them. Things like a heavy parasite burden, right? Or a previous history of respiratory disease or lymphadenitis, which is inflamed lymph nodes. They're also definitely seen more often on farms where S. equi strangles or R. equi infections are common.
Environmental risk.
Yes. And perhaps surprisingly, abdominocentesis, the belly tap procedure we use for diagnosis, is considered a risk factor if the needle accidentally punctures the intestine. That's called enterocentesis. It's rare, but it can happen and introduce bacteria.
Okay, so that covers the what and the why. Now, the big challenge, finding them. You said they're good at hiding. This must be where the real veterinary detective work comes in.
It truly is. Diagnosing these requires a really high index of suspicion. Because the onset is often so gradual, insidious, and the signs are nonspecific and intermittent, it's rarely a clear-cut case.
So what sort of subtle signs should owners or vets be looking for? What might raise that suspicion?
The signs are really variable, which is part of the problem, but a very common one, often slow to develop, is chronic weight loss or just poor body condition. The horse might be eating fine, but just not thriving.
Fading away almost.
Exactly. They can range from just looking thin and unthrifty to being severely emaciated, what we call pachectic. Recurrent intermittent colic is another big one, often a common reason they see the vet.
But not always the dramatic rolling on the floor colic.
Correct. It's often mild, low-grade, kind of non-specific belly pain that just keeps coming back. Weeks, maybe months, though you can see acute severe colic too.
Okay.
Fever is another key sign, often intermittent or maybe just persistently low grade, like 101.5 to 103 Fahrenheit. It might spike up when the abscess is particularly active or maybe starting to leak a bit.
Any other general signs?
Yeah, things like depression, lethargy, not eating well, or just picking at food anorexia or partial anorexia. General dullness, maybe poor performance if it's a working horse. And often a poor, kind of shaggy hair coat.
Just generally looking unwell?
Pretty much. Less commonly, you might see abdominal distension if there's a really huge abscess, or perhaps diarrhea or changes in manure, especially with our equine and younger horses. And very, very rarely, if an abscess is right up against the body wall, you might feel swelling or pain externally.
In the worst case scenario, if one ruptures, you mentioned that earlier, an acute crisis.
It is. That's an emergency. If it ruptures, you see sudden, severe signs of septic peritonitis. Acute, really bad colic, signs of shock, rapid deterioration, high fever, fast heart rate, profound depression. It's an immediate, life-threatening situation requiring urgent action.
Okay, so given these often vague, slow burn signs, how do vets actually pin down the diagnosis? What's the diagnostic journey like?
It always starts with a really thorough history and physical exam. Getting all the details from the owner is crucial. Focusing on those subtle signs, the weight loss, the recurring colic, the intermittent fever.
The timeline.
Exactly. And asking about any history of strangles, recent sickness, especially in foals, or any previous abdominal surgery. That's all vital information.
And the physical exam.
Assessing the horse's overall condition, carefully feeling the outside of the abdomen, listening closely to gut sounds which might be normal or could be decreased, and checking for fever. Rectal palpation is also key.
Can you actually feel an abscess that way?
Sometimes. In about 25 to 50% of adult horses, you might be able to feel a firm mass, something that doesn't move easily, maybe it's painful, especially if it's located towards the back of the abdomen, like in the mesenteric lymph nodes or pelvic area. But it's not always possible, especially if the horse is straining.
Okay, so history and physical exam give clues. What about blood work? What does that tell you?
Blood work can be very informative. A complete blood count, or CBC, often shows signs of infection, typically an increase in neutrophils, a type of white blood cell. Sometimes with what we call a left shift, indicating the body is churning out young neutrophils to fight infection.
Active inflammation.
Exactly. Anemia of chronic disease is also common if it's been going on a while. But a really key finding, very common and significant, is markedly elevated plasma fibrinogen.
Fibrinogen. That's an inflammatory marker.
It's an acute phase protein, yeah. It often gets really high, sometimes over 1,000 milli-GDL. Serum amyloid A, or SAA, is another one we monitor. It also indicates inflammation.
What about blood chemistry?
That might show high total protein and high globulins, hyperproteinemia, and hyperglobulinemia due to the chronic inflammation and antibody production. Often, albumin is low hypoalbuminemia, so the ratio changes.
So the blood is basically shouting chronic inflammation infection.
It provides a strong systemic signal, yes. It points towards a significant internal inflammatory process.
So you have history, exam findings, blood work pointing fingers, rectal palpation might find something. But it sounds like imaging is where you get the definitive answer.
Absolutely. Abdominal ultrasonography is often the most useful, really the definitive diagnostic tool in many cases.
Ultrasound.
Yes, we can do it transabdominally through the body wall, which is good for finding larger abscesses located more towards the bottom or sides, and also checking for any free fluid in the abdomen.
And transrectally.
Transrectal ultrasound gives excellent views of the structures further back in the abdomen. It's great for detecting smaller abscesses that couldn't be felt on rectal palpation.
What do they look like on ultrasound?
They have a pretty characteristic appearance. Typically, you see a thick-walled, encapsulated structure. Inside, the lumen might be anechoic black, meaning fluid, or it might have mixed echogenicity, showing debris and pus swirling around. They look like contained pockets of infection.
You can literally see the problem. Okay, what about taking a fluid sample? An abdominocentesis or belly tap, does that help?
It can. If the abscess is leaking or if there's already some peritonitis, the abdominal fluid collected might show changes, elevated total protein, a really high nucleated cell count, mostly neutrophils.
Signs of inflammation in the fluid?
Right. You might even see bacteria inside the cells under the microscope. Rarely free bacteria would culture the fluid too, but, and this is crucial, a normal negative belly tap does not rule out an abscess, especially if it's well walled off.
Good point.
And another really important caution. You should never try to stick a needle directly into an abscess to get a sample for culture unless you are immediately prepared for surgical drainage right after.
Why is that?
Because the risk of tracking bacteria out and contaminating the entire peritoneal cavity is just too high. You could turn a localized problem into a widespread, potentially fatal peritonitis.
Makes perfect sense. Don't spread it.
Oh, right.
Okay, so what if all these steps are still inconclusive? Or if you suspect surgery is needed anyway?
In some cases, yes, you need to go further. Exploratory laparotomy, that's open abdominal surgery, or laparoscopy, which is minimally invasive keyhole surgery, might be required.
To get a direct look.
Exactly. These allow for definitive diagnosis, let you assess how bad it is, see if it's removable, and often you can proceed with treatment right then and there. You can also do a fine needle aspirate of the abscess safely during surgery, or sometimes percutaneously using ultrasound guidance just before surgery.
And what do surgeons typically find when they go in?
They often find these abscesses involving the mesentery or organs like lymph nodes, intestines, spleen, liver, kidneys, and frequently there are adhesions, those scar tissue bands sticking organs together, which really complicates things.
Okay, so once you finally diagnose this hidden enemy, you start the treatment, which sounds like it could be a long road.
It absolutely is often. Treatment is frequently prolonged, and success really depends on many factors. The abscess's size, location, the specific bacteria involved, the horse's overall condition, and, very importantly, the owner's commitment. It takes time and resources.
What's the main strategy? Is it usually medicine or surgery?
Medical management is often the primary approach, the cornerstone, really. And that means long-term systemic antibiotics.
Long-term. How long are we talking?
Typically 1 to 3 months, sometimes even longer. Basically, until all the clinical signs are gone and those inflammatory markers we talked about, fibrinogen, SAA, have returned to normal and stayed there for a while.
Wow, months of antibiotics.
Yes, and stopping too early is a common mistake. It can lead to the abscess flaring back up, recurrence.
How do you choose the right antibiotic with all those potential bacteria?
Ideally, you base it on culture, and sensitivity results from a sample of the abscess fluid if you could safely get one. But often that's not possible initially, so you start empirically.
Meaning based on the most likely culprits.
Exactly. You use broad-spectrum antibiotics known to penetrate well into abscesses. Think of it like a chemical siege trying to get through that thick abscess wall. Common choices include penicillin, maybe combined with metronidazole for anaerobes, or gentamicin. Sometimes drugs like ceftiofur, doxycycline, or enrofloxacin are used.
Are they usually injections or pills?
For such long-term treatment, oral antibiotics are often preferred if possible, just for ease of administration. Things like trimethoprim sulfa, TMS, maybe combined with rifampin or doxycycline. But sometimes intravenous or intramuscular injections are necessary, at least initially. Penicillin, for example.
That must be tough on the horse and owner for months.
It can be. Compliance is a challenge. Horses can become intolerant to repeated injections. It requires dedication.
What else is involved on the medical side? Just antibiotics?
No, definitely not. Anti-inflammatory medications and NSAIDs like flunixin or phenylbutazone are really important to manage fever, pain, and systemic inflammation. Though again, long-term use needs careful monitoring for side effects like ulcers or kidney issues. Supportive care is also vital. Good nutrition is key to help them regain weight, high-quality forage, appropriate concentrates, fluid therapy if they're dehydrated or really sick, and sometimes probiotics or prebiotics to help support the gut during that long antibiotic course.
And owner education sounds critical.
Paramount. They need to understand the long commitment, the potential costs, and the importance of sticking with the treatment plan exactly. Most cases, thankfully, can eventually be managed on the farm, but some might need hospitalization, especially at the start, and rest, stall, or pasture rest until things are resolved.
Okay, so that's the medical marathon. When does surgery become the better option? It sounds more invasive.
Surgery is generally considered if the abscess isn't responding to medical therapy after a reasonable time, if it's causing severe signs like ongoing colic or obstruction, or if it happens to be in a location that's actually accessible for drainage or removal. It's sometimes attempted in cases that look pretty grave otherwise.
What can they actually do surgically?
Several options. If an abscess is right near the body wall, visible on ultrasound, they might be able to perform percutaneous drainage, sticking a catheter in to drain it externally, but that requires very careful planning to avoid contaminating the abdomen.
Precision work.
Definitely. Laparoscopy keyhole surgery can sometimes be used for drainage or even removal if the abscess is suitable and accessible. Then there's open abdominal surgery, laparotomy.
What happens then?
If the abscess is stuck to the inside of the abdominal wall, they might do something called marsupialization. They cut into the abscess and suture the edges of the abscess wall to the skin incision. This creates an open draining tract that can be flushed regularly.
Sounds intense.
It is. Sometimes, if the abscess is small and well-defined, maybe within a piece of bowel that can be removed, or an isolated lymph node, they might be able to resect it, cut it out completely. But that's often difficult because of those adhesions we mentioned.
The scar tissue gets in the way.
Right. Very rarely, they might do bypass procedures if there's severe intestinal obstruction. And critically, if an abscess has ruptured, causing that septic peritonitis, then aggressive abdominal lavage, flushing out the abdomen with huge volumes of sterile fluid during surgery, is absolutely essential. But even that has its challenges.
It all sounds incredibly complex and demanding. How do you track progress? How do you know if this long, expensive treatment is actually working?
Monitoring the response is key. We look for several things. First, clinical improvement. Is the fever gone? Is the appetite better? Are they gaining weight? Are the colic episodes stopping?
The horse looking and acting better.
Exactly. Second, blood work. We serially monitor those inflammatory markers, fibrinogen and SAA. They should steadily decrease and head back towards the normal range. That tells us the inflammation is subsiding.
Tracking the internal battle.
Precisely. And third, repeat ultrasounds. Periodically, we'll re-ultrasound the abdomen to check the abscess itself. Is it shrinking? Is its character changing, becoming more organized or resolving? That visual confirmation is really important.
So putting it all together, what's the bottom line for the horse and owner? The prognosis. It sounds like a really tough condition to beat.
The prognosis is generally considered guarded to fair, but it's highly variable. It really depends.
Guarded to fair. So not great, but not hopeless.
That's a good way to put it. Some older studies reported quite low survival rates, maybe around 25% in certain groups. But with modern approaches, especially for specific types like Strangles-related abscesses treated medically, success rates can be much better, maybe 50% to even 80% in some reports.
That's more encouraging.
Yes. And generally, if the horse shows a favorable response within the first couple of weeks of treatment starting, the prognosis tends to shift towards good to guarded.
What factors really make the difference in the outcome?
Several things. The underlying cause, the etiology, is important. Abscesses from strangles spreading to mesenteric lymph nodes often respond better to medical treatment alone compared to, say, an abscess caused by a bowel perforation. Size and location matter too. Smaller, easily accessible abscesses are generally easier to manage. Big ones, multiple abscesses, or ones buried deep and stuck to vital organs, have a poorer prognosis.
And rupture is obviously bad news.
Extremely bad news. If it ruptures causing diffuse septic peritonitis, the prognosis becomes grave to poor, even with immediate aggressive surgery. Complications also worsen the outlook significantly. Things like severe adhesions causing chronic colic, persistent intestinal obstruction, or systemic immune problems like purpura hemorrhagica.
That sounds nasty.
It is. Also, how long the abscess has been there can matter. Really chronic, long-standing ones with thick fibrous capsules could be harder to resolve. And of course, the specific bacteria involved and its susceptibility to antibiotics play a role.
And I guess the practical side owner commitment and finances must be huge factors too.
Absolutely critical. As we said, treatment is often very long, it's expensive, it requires prolonged medication, potentially multiple vet visits, diagnostics, maybe even surgery. That commitment is essential.
What about long-term consequences, even if treatment is successful?
Even with successful treatment, horses can develop chronic adhesions inside the abdomen. And those adhesions can potentially lead to recurrent colic episodes or maybe limit athletic performance later on. Recurrence of the abscess itself is also possible, especially if treatment is stopped too soon or the original underlying cause wasn't fully dealt with.
So it can leave its mark. After diving deep into diagnosis and treatment, what about trying to prevent this in the first place? Any strategies?
Prevention is tough because the causes are varied. But on farms where you know you have issues with S. equus strangles or R. equus in foals, then careful monitoring of all horses, especially the young ones, might help with early detection, catching problems sooner.
Vigilance.
Yes, and specifically, if strangles is a recurring problem on a farm, then implementing a vaccination program should definitely be considered. It can help reduce the incidence and severity of strangles, and therefore potentially reduce the risk of complications like these abdominal abscesses.
Okay, so to wrap this up, equine abdominal abscesses are, well, undeniably challenging, a true hidden threat in horse health.
No doubt about it.
But with early suspicion, a really thorough diagnostic workup, and aggressive, often very prolonged medical or sometimes surgical treatment, a positive outcome can definitely be achieved in many cases. Vigilance for those subtle chronic signs is just so key for you, the horse owner or enthusiast.
Absolutely. This whole deep dive into these abscesses, it really highlights something interesting, doesn't it? How even seemingly vague chronic symptoms in an animal can point to a much deeper hidden problem.
Right.
It kind of makes you wonder what other subtle, persistent signs, maybe in our own lives or just in the world around us, might be indicators of an underlying issue that really requires a proper deep dive to understand and maybe finally resolve.